Good morning, everyone. Hi, this is very exciting. I'm Diana Barnes. I'm kind of stunned and overwhelmed to see so many people here this morning. I am the chair of the International Marce Special Interest Group on Forensics and Maternal Mental Illness. And our group that's been operating for the last few years really has been looking at the intersection between law and maternal mental illness and kind of taking a deeper dive into understanding cases where women have been criminally charged. We're recognizing that what we need to do as a community is to really encourage and instill a more compassionate view and a more compassionate perspective in the legal arena. If for some reason we have so much to talk about today, if for some reason we don't get your questions answered, we really want to encourage you to write into us. We will answer them. And in addition to that, we invite you. We meet monthly. I see Kathy Wisner on the line, one of our members. Hi, Kathy. And so we certainly invite you to come and join us. We meet on Tuesday mornings once a month, and you can get that calendar from Kelsey. Really today, the question that we're asking, and we certainly invite your participation, is, what are we missing when it comes to postpartum psychosis and infanticide? What do we need to be paying more attention to? Why does this continue to happen? And as someone who does a lot of forensic work, I am asking that question all the time because I'm coming in on the other end of these heartbreaking tragedies. So let me introduce you to our presenters today. Dr. Margaret Spinelli, who's going to be moderating. Everybody, she needs no introduction. She is the clinical professor of psychiatry at Columbia University College of Physicians and Surgeons. She's been testifying in court for infanticide cases since 1994. She is my mentor and my inspiration for the forensic work that I'm currently doing. And Dr. Spinelli is currently working on the Lindsay Clancy's case, the Boston nurse at Mass General who killed 3 children during a postpartum psychotic episode. Let me introduce you also to Dr. Ariana DeFlorio, who is a professor of psychiatry at Cardiff University in the United Kingdom, where she has not only set up, but also led the Reproductive Mental Health Clinical and Research Program. This is the only program of its kind in the UK, integrating both research and clinical practice. Her research has been published in major academic journals, including Nature Genetics and Lancet Psychiatry. And Ms. Ritika Beal has more than 12 years experience of teaching law students, which includes her 11 years tenure at Amity Law School, Amity University, Uttar Pradesh, before joining the Alliance School of Law, Alliance University, Bengaluru. She is pursuing her doctoral research at the Symbiosis International University in Pune, India. Her doctoral research is dealing with perinatal depression and women's rights in India. She is the only law professor included in the executive committee of the South Asia Marce Association, which is a regional group of the International Marce Society. Ms. Ritika has various international and national publications in her credit, including Scopus Index publications related to women and child rights, including in archives of women's mental health. So Meg, I'm going to turn the platform over to you.
Okay. Good morning, everybody. Thank you for coming. So our goal today is to raise questions and provide some answers on postpartum psychosis and infanticide, which is really a subject that has been avoided essentially in perinatal psychiatry. I'm going to present data from my own experience with women. Dr. Ritika Beal will describe her experience in India, and Dr. Ariana DeFlorio will describe her excellent new genetic study about first onset postpartum psychosis. So I'll slides, please. So this is a picture of women in an insane asylum in the 19th century. The postpartum psychosis caused lots of deaths at that time, both from overactivation and dehydration. Next slide, please. Kelsey. Oh, thank you. I'm not going to go over symptoms and signs. We all know them. I just want to call your attention to this study that was done by Kemperman, and it's a prospective clinical trial in 130 women. And what is so impressive about this is that this trial replicates 50 years of our literature and the same kind of symptoms that occurred back then. Next, please. As we know, postpartum psychosis was never included in the DSM, and the words purple and postpartum were expunged from American psychiatry. And it was due to two psychiatrists, Strecker and Ebow, who basically did chart reviews and said that there was no such thing as postpartum psychosis. And for some reason, American psychiatry just clicked onto that, and that became their belief. Next, please. I should just tell you that at this time, there are proposals with the DSM that hopefully postpartum psychosis will be admitted into the DSM. And so I've probably evaluated 35 women who commit infanticide. Not one was diagnosed or treated. Obviously, if we didn't have the diagnosis in the compendium, medical students, psychiatrists, residents never learned about diagnosing postpartum psychosis. Next, please. Now, in the United States, women can go to prison for a lifetime, and yet we have the highest rate of infanticides in the Western world, almost twice that of other Western countries. Next. And these are three areas of interest that I think most of us don't know about with postpartum psychosis, and I wanted to call your attention to it because they're important. The first is the diagnostic dilemma between intrusive thoughts and psychosis. Many of us think that we can resolve this by asking, do you want to harm your baby? Thinking that the woman with obsessional intrusive thoughts wants to, but does not want to, but psychosis does. Well, I have been informed that the women during a postpartum psychosis do not want to harm their babies, for the, at least some of them, but they are struggling with the very controls that, or the very, the forces that control them at the time. So most important, it is to examine the intrusive thought or the psychosis or the hallucination for content, and then evaluate any evidence of psychosis in general. Next, please. Now, this is something that has impressed me. And it seems like these women report over and over again that there is this overpowering force or pull of control while they remain passive like puppets. Next slide. This was a case from about 15 years ago where I first heard this. She said that there was a pulling inside and that this urge had control over her. And I couldn't understand what she was saying, so I asked her to draw it because I thought, well, is this a compulsion? Because she's calling it a force. Next slide. And so she drew pictures for me of before, during, and after. And you can see that she describes this force as a monster that she could not control, and that she was then like a puppet or a marionette. And women describe this over and over and over again. Next slide. So one of the women described, the thoughts were not mine. There was an urge that I could not control, and a relentless, loud voice kept repeating, stab her. It was almost like a magnet pulling me across the kitchen floor, or someone pulling my hair. I was like a puppet. Next slide. As I mentioned, we have some very harsh treatment here in the United States. This is a case of Cara Coronado. In 2014, she experienced command hallucinations to stab her 3 children ages 24, 16, and 2 months during an episode of postpartum psychosis. After she stabbed them, she arranged her children and herself naked in the shape of a cross on the bed. She then plunged a knife into her chest. Now, the judge sentenced her to 3 life sentences and 3 years, which was a horrible show of hostility on his part from someone who we believe should be non-judgmental. Next slide. Now, our US criminal law demands not only that the person have a psychiatric illness, but also the cognitive inability, was not able to know right from wrong. And for those of you who do deal with this insanity defense, I just want you to know, next slide, that there is a century of scientific literature in our literature that describes the cognitive impairment and confusion associated with postpartum psychosis. Next, please. Here is the list, if you should need them, for court, if you happen to be testifying, and so that these cases can also fulfill all of the issues in McNaughton. Next, please. This is what disturbs me. What disturbs me is this picture is not unlike the one that I showed you, and that we are remiss in not studying this illness more. And I think what I have learned, specifically from the woman Gina and the others, is how much heartbreak, even if they did not kill their children ultimately, how much heartbreak this caused them at that time and caused their families. So I hope this relatively new information with you has been helpful. And so I'm going to introduce Ritika Beal, who will tell us about her experiences in India.
Thank you so much, Dr. Spinelli. I just have one thing to ask Dr. Marce. Do we continue with the same schedule we had decided, or we can moderate it?
No, you can continue. Go ahead.
Okay, thank you. I'll start sharing my slides. Please let me know in case it is not visible to anybody. I hope it is visible to everybody. Are the slides visible?
Yes, they are.
They are.
Okay. Good morning, everybody. Today, I will be talking about postpartum psychosis in India and India's justice dispensation system. So basically, India is a party to various international core human rights treaties, because of which it becomes incumbent upon us to adopt rights-based approach in India, and thereby it becomes pivotal that we provide mental health and especially perinatal mental health services to women in India. We have introduced multiple and multitudinal laws to ensure that we are abiding by our international treaty obligations. But when we look at perinatal mental disorders, in India, it is an unrecognized public health issue. More so, especially when we are talking from the legal side of it. There is a pervasive gap, a policy gap which is existing, and there is lack of awareness about perinatal mental health disorders, especially perinatal psychosis, which is existing at different levels, whether we talk about healthcare level, whether we talk about legal system level, or per se at society at large. More so in India, when we talk about perinatal mental disorders, there is a cardinal role which is being played by psychosocial factors, which has to be kept in mind, because of which we cannot per se limit perinatal mental disorders within the psychiatric field or medical science field. We need to understand its cross-cutting nature when we are talking about Indian society. So it translates into medical anthropology. So we need to understand how people experience it, how people relate to it, and how people try and deal with it. This brings us to infanticide in India. Infanticide in India has been a longing issue. It has been a social level which has been existing for decades. But the manner in which infanticide is perceived in India is altogether different. Because when we talk about infanticide in India, it is dealing with gender bias which is existing against girls, especially because girls were treated as a burden for the families. So there is a completely different approach towards infanticide in India. Though infanticide per se in India is regarded as a social and legal issue, but the whole idea is to protect girl child, not to protect the child in India. So the approach is not to look at it from perinatal mental health disorders perspective, but look at it as a social issue per se. And because of this, even though there have been around 9 million girls who have been missing in India since 2000 to 2019, there hasn't been much which has been done to understand exactly what has been the reason, what have been the root causes to it. But it has been given the shield of killing girl child in the name of them being a burden on the family. There have been multiple schemes also which have been introduced in India, like cash transfer scheme for girl child, so that parents wouldn't take them as a burden. But largely, when we look at the law enforcement agencies in India, they remain unaware about perinatal depression and perinatal psychosis. Though there are disparities in state laws, individual state laws which are found in India, because couple of states like Kerala, Orissa, they have introduced criminal laws where they understand that they need to commute the sentence in case a woman commits infanticide in India. But largely speaking, such laws are missing in India. Now, what is infanticide under the criminal legal system in India? We treat it as a criminal offense, and here we try and understand that it is not equivalent to a murder, and it also covers neonaticide in India. So, in India, there is not much difference between infanticide and neonaticide per se. And we understand infanticide as a crime which is committed where a child is prevented from being born alive, or we cause it to die immediately after birth. So we don't understand it from this perspective that the women under the effect of a mental health disorder can commit such an act. We understand it that because of the society's approach towards the gender bias against girls, women tend to commit such crime. So, though there are gender-colored legislations which we have introduced in India, but they do not cater to protecting the child per se. And as Dr. Spinelli rightly mentioned, that when we are talking about McNaughton rule, these are aspects which have been affecting Indian criminal legal system as well, because mens rea, that is the intention to commit the crime, as well as actus reus, that is the act which we undertake based on that intention, both need to be present when the act is being committed. And not guilty by reason of insanity. That is another rule which is based on McNaughton's rule in India. It provides that any act where such act is being performed under the influence of mental illness, that should not be regarded as a criminally liable act. But again, it requires a proper diagnosis, because under the Indian Evidence Act, it is upon the accused. They have to prove to the court that they are affected by perinatal psychosis. So automatically, the disparity which is existing in different states' criminal laws, they start affecting women's rights, their rights in every aspect, more so because of the complete lack of awareness among the law enforcement agencies, which includes judges, advocates, and police force also. We see that there is a completely different approach. Instead of providing help, treatment to such women, we treat them as criminal offenders, though there might not be any criminal history. And more so because we don't understand the fact that there is complete absence of standard protocols which call for diagnosis. The judges also don't understand that this is a policy gap which is cross-cutting in nature, which is affecting our justice dispensation system. In case there is no diagnosis which has taken place, they treat the women as a criminal offender. And there have been cases where women have been sentenced to imprisonment. So therefore, we can conclude over here that there is a very limited understanding of infanticide in India, more so in context of perinatal psychosis. There is a complete miscarriage of justice which has been carried on, especially in those states where there are no criminal laws dealing with women offenders of infanticide and commuting their punishments. This brings us to this aspect, that what do we need to do? What, according to me, we need to do is we need to read this whole phenomena of infanticide and perinatal psychosis from the lens of human rights, where we understand that this whole aspect is transdisciplinary in nature. We cannot segregate it into different compartments, and there will always be different disciplines which need to be integrated together. The knowledge from these disciplines has to be integrated, where none of them will be acting as a superior to the other, but would be informing each other. So when we will start understanding, when we'll have better understanding of perinatal mental health disorders, especially perinatal psychosis, that should translate into the criminal legal system. Once it translates into the criminal legal system, it should automatically be read from the lens of human rights law per se. If we try and undertake such kind of transdisciplinary research, I believe it can bring out more awareness in the society, which obviously will be more helpful in changing the political will, which undoubtedly will further translate into the criminal justice system. So probably my 1 cent from this is probably we should be looking at the cross-cutting nature and try and read this phenomena through different lenses, so that we can pursue our policy makers to ensure that there is more awareness about perinatal psychosis and infanticide from the lens of human rights law and psychiatry together. Thank you so much.
Thank you, Ritika. You know, I just want to comment that what you're talking about, the misogyny, that I look back on those years with the DSM and see that exactly the same thing, and that it continues in the United States as well. So now Dr. Ariana DeFlorio is going to give the results of her wonderful genetic study.
Thank you, Dr. Spinelli. I can share my own screen if that's okay.
Absolutely.
Is this big enough? Can you see this?
Yes.
Wonderful. I'll start with a brief introduction, because some of you, like me, might find the word nosology itself really off-putting and unappealing and too abstract. I think Dr. Spinelli has provided you already a very beautiful introduction on why this is really important. Why is it important to give a name to this condition that affects women after giving birth? And this is clinically really important. for me, it was important, the encounter with a patient that made the point that actually diagnosis matters for them as well. It's really important for women with lived experience to be able to name their disorder. And then other names that we are currently giving to postpartum psychosis, which could be the wrong, really wrong and dangerous name of postpartum depression, bipolar disorder, they're not valid. We need this entity in DSM. So what does even validity mean in psychiatry? It's kind of a strange word to be used in the context of mental illness. I usually give a 1 hour lecture on the topic. We don't have time today, so I'll be very brief, and probably I will oversimplify concepts, and I apologize for this. This is a very highly debated and controversial area, and as Dr. Spinelli said, I think misogyny plays definitely a role here. There are different points of view that we can use for this. I'll follow the point of view of DSM, which is what unfortunately rules a lot of our clinical practice in Western medicine. And DSM propose a number of validated criteria that an entity like postpartum psychosis needs to meet to be called disorder. Those here in bold, this is the list, are those that are considered most important. For the sake of this presentation, I'll focus on molecular genetics. So if you want to include any disorder in DSM, the DSM committee will ask you, provide evidence for these validators. I'll focus for these on the validators for postpartum psychosis related to molecular genetics. Why molecular genetics? Because it's easy. It's really easy. Because DNA is fixed at birth, so you don't have you have less issue with inverse causation. It's the same in all cells. So you can take samples, for example, like you can make people spit. It's much easier than a COVID test. So it's very easy to collect. And you get from cells, for example, from the mouth, you get information, the same information you would get from the cells in the brain. I think it's key to understand the study I'm going to present today, that you understand how DNA, what DNA is, basically. If you go to the Wellcome Collection in London, they used to display these books. And if you look at the content of this book, you'll discover that they're written just in 4 letters. These letters are the building blocks of our genetic code that is called DNA. This one library here represents the code for just one person. So we've got a lot of it in each single cell we have in our bodies. Now, the code is almost identical for all of us. What makes us unique from a genetic perspective is just less than 1% of the code. I think the trick to understand why this is relevant for postpartum psychosis is that for any disorder, the significant part of our risk of developing the disorder is given by many spelling variations in these books rather than a single one. And none of these variations taken singularly has got a big effect, but it's the accumulation of them that influences the risk of developing a disorder. In other words, going on with keeping the metaphor of books here, let's say you want to know whether someone is native speaker, English native speaker. Now, Jess speaks English as a first language and will make some spelling mistake, but not too many, okay? English speakers here follow this bell shape. So we all make some mistakes. Most of us make some mistakes here in the middle. Some really good people at English are here on the bottom left, and on the right, you have people like me that don't speak English very well. So the risk you have, if you call, of Britishness in this case is really high if you are on the left and very low if you are on the right. So Jess, for example, is first language English speaker. She doesn't make many spelling mistakes. She's quite likely to be British as a first language. Me, on the contrary, a lot of spelling mistakes, very low likelihood of being British. And it's the same, exactly the same for any disorder. In this case, let's say bipolar disorder, postpartum psychosis, you got your genetic score for bipolar disorder. If you have a high score, you're here on the right, your risk of bipolar disorder is high. If, on the contrary, you've got very low genetic score for bipolar disorder, your risk of developing bipolar disorder is really low. How can we use this for the study here? We want to demonstrate, and this is really key here, DSM has got it's quite easy if you think, because it got very set rules, really rigid. So if you want, to demonstrate that something is worth to inclusion in DSM, you need to prove that this is different from what is already there. In this case, we want to prove that postpartum psychosis is different from bipolar disorder. Why bipolar disorder? Because it's quite similar. And in general, women, because there is no other label around, they're labeled bipolar to have bipolar disorder. Even if that's not true, even if they've never had it before, they've never had anything after. This is the first episode of postpartum psychosis we're talking here. They get the label anyway. So we need to prove biologically that actually these two entities are distinct. So we want the bell-shaped curve for postpartum psychosis to be separate from that from bipolar disorder with a zone of rarity in the middle. The results I'm going to present are in this study that you can read in Lancet Psychiatry. I won't go into the details. There is also an editorial that you can read on the topic by the Lancet. So here you can distinguish these are the results. This is it looks like a small sample, and for genetics, it is a small sample of women with first onset postpartum psychosis, but it's still quite significant. It's over 200 women. We compare their DNA with that of over 1,000 women with bipolar disorder who gave birth. So we know, like there were Paris women, so we don't have that confounders, and then female control for the general population. What we observed, women with bipolar disorder is the blue line here. We knew that we're going to have high risk, genetic risk of bipolar disorder because they do have the condition. We also know that bipolar is highly related to schizophrenia, so no surprise they have also here in the middle high risk genetic score for schizophrenia. And we also know that bipolar is everything basically in psychiatry is related to the genetics of depression, so we're not surprised about this line here as well. Postpartum psychosis is similar to bipolar disorder genetically in terms of the risk of bipolar disorder, also schizophrenia, I would say, but this is a long and complicated story. But for today, let's say that it is. What they really look very different from women with bipolar disorder is the risk for depression. Genetically, they don't have any risk for depression, these women. They're very different. Their genetic architecture is very different from bipolar disorder if we consider the risk for the genes that influence the risk for depression. And I want to focus on this because this is an unicum in psychiatry. Okay, all disorders, and this is the figure on the right, all disorders are kind of related with major depression. You can see here ADHD is related, anxiety is related, bipolar is related. They are all basically related. Let me see here. You can see OCD is related, schizophrenia is related, Tourette is related. Everything in psychiatry is really related genetically. The genes that predispose you to major depression usually predispose you to also other things. Okay, they're really correlated to each other. And this is the really, if you do psychiatric genetics, that's a bit messy because everything is correlated. In this way, postpartum psychosis is a unicum because it's not correlated to those genes. It's its own thing for this, in this dimension. And it's very similar actually to people in the general population. Your genetic risk for depression, if you have postpartum psychosis, is the same than the general population, is not higher. So these matters are really important because we tend to conflate postpartum depression with postpartum psychosis. That's quite a common, like we know that both from the inquiry into suicide, which is a leading cause of maternal death in the UK, but also from studies that have been conducted also by Dr. Spinelli and most recently by Alessandra Bramante in this cohort in Italy, that usually misdiagnosis, or as Margaret said, the fact that people are not diagnosed at all, it is a major factor, risk factor actually to commit infanticide or to die by suicide. So it's really important to distinguish between depression and psychosis. I don't think they are the same. People that think they can put together all postpartum disorders, I think that is biologically not valid, is not correct to do so. And I think we need to revise that. This is what I've presented today is just a small piece of a larger puzzle, like to include postpartum psychosis as a separate nosological entity in DSM, but it's a very important puzzle because it's a biology, it's less prone, as I say, to confounding. It's quite hard science, and hopefully that will help the process with DSM. but also I think at large, like the culture around this topic. Thank you to my team, and of course to the many women that over the years, they've been amazing taking part in this research. We've got over 8,000, people with bipolar disorder, postpartum psychosis taking part in our research. So we're very grateful about that. Thank you.
Yes, so we can take questions if anyone would like. I believe some questions were submitted. Is that right, Diane?
Kelsey, were there some questions submitted before?
No, I didn't get anyone to submit any questions.
So if there are any questions, we understand that this was a very, very quick oversight of each of these issues. But we would like it if you have some questions, we're happy to answer any of them. Yes, Dr. Wisner.
Ariana, I was intrigued, and I want to make sure I understood correctly that the polygenic risk scores for people with postpartum psychosis are similar to the general population. Did I understand that correctly? So, and this made me think about something that I've wondered about for years. We have been looking at reproductive hormones, estrogen, and relationship to these postpartum onset disorders. And one of the things that I wonder is whether the more acute onset psychosis that we see is really a steroid withdrawal psychosis, not just estrogen, but the fact is all of the steroids come plunging down. And in a couple cases of postpartum psychosis, I've seen women with psychosis become psychotic when they have like steroids for poison ivy and then stop the steroids, but no other episodes. So, wonder if there's this small group of people similar to most people, but who are particularly sensitive to some kind of massive steroid withdrawal. Just one final thing. There's a paper from the 1960s by a British woman. I think her name is Ione Railton. And what I thought was interesting was she treated women with postpartum disorders with prednisone and claimed that they were well in a week. Now that could certainly be some inflammatory thing. But anyway, I've been intrigued with this and not quite sure what to do with it for a long time. So I just wondered what your thoughts are.
Thank you. It's really interesting, really interesting. I do believe there are probably, even if it's a rare disorder, I think within the rare disorder, there are many subtypes. And we're starting from, like understanding some of these with case reports, again, very important, clinical experiences. And I wonder whether that is actually the right approach to this clinically, like very clinically defined phenotypes, as we say now in genetic research, I think that is the way forward for these conditions. And definitely, I think there might be cases like that. We're running now a study on menopause-related psychosis. And we're seeing exactly very similar behaviors. And that makes me think.
It's fascinating because when about 20 years ago, I saw a patient for a menopausal psychosis look very much like a postpartum psychosis. And as I interviewed her, she said, she was from England. And she said, I had this after the birth of my last child and they treated me with estrogen. Can you give me estrogen now? So I have wondered about that menopausal psychosis. Are you seeing that a lot of those women had postpartum psychosis?
Some of them had, and it's very interesting is if the menopause occurs surgically, so the withdrawal is more sudden, I think the numbers are larger in that group. Whether that is going to be replicated systematically is another question. But again, I think there are many small subgroups. And then there is the epistemic questions on how do we investigate something that is that rare. But I think there are definitely these people, and as experts, we should know about these different groups. What we observed in general, in the general UK population, well, it's not very general, but it's quite general UK population, is that there is an increased risk of first onset mania in the 2 years surrounding the final menstrual period. It's a 3 times increase compared to other times. So I wonder whether, again, there is something about some bipolar vulnerability that is shared with a hormonal trigger, and that is very different from the depression one. I think that is something we need to emphasize, especially in a forensic setting. Then depression is different from this thing. It's nothing to do. You know, like there might be a spectrum and stuff, but you cannot confuse the two. I think that is a very important message. And also think about, Katie, about your research on the bipolar symptoms around the perinatal period, the manic symptoms. You know, like I think it's those symptoms are very often neglected. I don't know what you think. You're definitely more experienced than I am. You know, like about this distinction. I think that's key. We cannot give antidepressants to these women. That is my clinical point. And I think that is one of the major risk factors on this forensic conversation.
Yes. Ariana, I have a question. Was I wrong to take from your article that first onset postpartum psychosis without subsequent bipolar episodes, but only at delivery, that it is a variant of bipolar disorder?
I think it depends. Yeah, I agree with you. I think it looks like they share a lot genetically, but bipolar itself is a lot, right? It's a lot of different things.
Yeah.
You can see people that have had depression all their life, and then they've had a hypomanic episodes that is very difficult to even, you know, recall. And that would be a bipolar 2 diagnosis, you know, like, and then you've got the schizoaffective, especially, I think in Europe, we use that. In the US, probably it would be more bipolar 1, you know, like that area in which people got this really severe psychotic episode. And all of that we call under the umbrella bipolar. For a group of women with postpartum psychosis, which I think is quite a good group in terms of size, a sizable group, sizable enough to be statistically detectable, they belong to that spectrum, to that bipolar umbrella.
Oh, okay.
But they are different from most people under that bipolar umbrella, because most people in that bipolar umbrella have got also a lot of biology of depression.
Yeah.
Well, these people, if you want, I see them as the purest of pure bipolar, because they have got this risk for mania, you know, for strict there, and not all the rest that comes with bipolar. Usually they have episodic episodes, right? They are well between episodes. You can treat them. They don't come to you every month being depressed. You know, like it's a different pattern of illness. In the huge kaleidoscopic presentation of bipolar, like the beautiful island, that's the complexity of bipolar.
Yeah.
But I still believe there are certain that have nothing to do with bipolar, because it can be autoimmune, it can be, you know, it can be something else. But those groups probably are too small to be detectable in a study that uses statistics.
Okay.
And that's why clinical studies, case reports become really important and vital. And I think we are missing academically, this is a strong point I want to make, sorry, and then I shut myself up, is that we're missing that now. Everything is on big numbers, everything is registry data, right? That's how we do knowledge now. We crunch data in computers. I think we should go back to also clinical cases, phenotype data, case reports, especially for these conditions.
Okay.
So true, and that's, I think, Meg's, the thing that strikes me about Meg's video is, you know, early on we're saying, well, these are acute onset psychoses within 24 to 48 hours. And Meg's is this sort of slowly evolving case that, you know, really goes against that kind of acute onset definition. And I think that's really important. I really agree with your point about clinical concern. So I've seen a couple cases of psychosis in preeclampsia that continues and looks kind of like a delirium even after the preeclampsia clears. So I think there are all kinds of variations that we just don't capture well.
As a matter of fact, it's interesting because I was going to add to you what you said, Kathy, is that Tina actually uses the word morphed into anxiety. So she describes the progression, and which is really the antithesis of what we've come to understand as kind of sudden onset.
Yes, what I've seen is a lot of women have more anxiety initially. And then they're often diagnosed, oh, they must have obsessive compulsive symptoms. They're given a antidepressant, and then they become manic.
I noticed that Adrian had her hand up. Adrian, did you have a question?
I did. Thank you all. This has been fascinating. Could you repeat the thing about the connection with poison ivy and the steroid? I didn't grasp that.
So it's this sort of sensitivity to steroid withdrawal and getting steroids for poison ivy, or I've seen it for rheumatological disorders, and then when the steroid stops, they become psychotic. So I wonder if it's this kind of replication of loss of steroids that's a vulnerability for some, I think, very rare individuals.
Thank you.
Questions?
I think we have another question, Maythree.
Hi.
Hi, thank you for a very fascinating all the presentations are really fascinating. This is somewhat of a departure from what we were talking about, but I was wondering if folks could talk about the interface with child protection systems and these cases. And I work in a setting where I think these systems are quite flawed, and there's talking about misogyny and racism that exist within them as well, and sort of how they interface around these cases. I was curious about people's thoughts.
I have only had one experience, but and that was of a woman who had a previous postpartum psychosis. And when she was about to deliver her second baby, and that child had been taken away from her. And when she had a second baby, social services came in and did the same. It was a more problematic relationship, but that's all on my part. Does anybody have any more information on child services with these cases?
Well, I know from my experience, usually coming in after the tragedy has already occurred, then of course it makes sense. The Child Protective Services has come into the picture. I have a current case where this was a woman who was in the system, in and out of the system. A child died. And interestingly, the child died about 2 days after a wellness check, in which Child Protective Services cleared the decks, said she was doing a wonderful job. She had met all the requirements. And then this child died. And it's still, there's speculation as to how this child had so many, it was an abuse that caused the death of this child. And there's still questions unanswered as to how this child had so many bruises and scarring and burns, and Child Protective Services gave them a clear bill of health.
I believe Child Protective Services came in on Gina's case for a while also on the film.
I've actually also had civil cases, not criminal cases. I've had a couple where the children were removed from the home because of misunderstandings, even about postpartum depression. Children were removed from the home, and then it was really hard for these mothers to get their children back into the home. I mean, the hoops that they had to jump through, and it took, in some cases, it took over a year for these mothers to prove themselves as fit.
I wanted to add something that's happened to me this week, actually. I didn't need to renew my child protection training in the UK. And one of the questions was, Clara's got bipolar disorder. She says she's a good mother, true or false? So this is the training that healthcare professionals in the UK get as a question for these topics, okay? So of course, now the question has been deleted because I made sure that that was going to happen. But I think we should not underestimate the stigma around these topics, really.
Oh.
Both ways, okay? Both ways, but yeah.
And also the misogyny.
Yeah.
That has only dawned on me recently, and I've gotten more and more angry over it.
I'll join you in your anger. At my previous organization, I had wanted to consult on a case of a woman who had killed her child. And this was in Northwestern. I got a call from the legal group in the organization who basically barred me from doing that work because they thought, if I were defending somebody who killed her children, it wouldn't look good for the organization. So talk about stigma. My comment to them was, so it's guilty until proven innocent. And, they just basically barred me from doing it. So it isn't just, it's stigma writ large that we're really fighting. It was terrible. And we have there was a forensic psychiatry department. So anyway, difficult, very, very stigmatized.
And actually add and the general population, because no one identifies these women. And so often in the course of these cases, people will say, I never heard of this illness. So I think we have much more education to do.
I'm aware that we're coming to the end of our hour today. So are there any last minute questions? Otherwise, please feel free to write to any of us with your questions and we will make sure that they are answered.
So can I just ask, so Maggie, is it time to do another big APA educational event?
Definitely.
Yeah, really. I mean, I think you're so right that people are missing. I just saw a woman today who got suicidal when she was given an antidepressant for her postpartum depression. She was clearly bipolar. I really, well, I don't want to prolong this, but we need to do something more.
Yeah, we need
really
to do another workshop because
this is terrific. Thank you.
Yeah, and as I have said, we keep publishing in women's psychiatric journals. We have to get it out there, okay, to other, American journal, clinical journal, because the psychiatrists still do not know how to diagnose.
And to that point, given many of these women are treated by their OBGYN or the pediatrician notices when they give an EDPS or the primary, I mean, thinking not just general psychiatry journal, but medical journals, right? General medical journals, general medical conference, because a lot of this is being treated, the majority is being treated not by psychiatrists in terms of giving an SSRI postpartum, right? And what the implications could be.
So we should think about a workshop for APA next year.
Not just APA. I mean, this like we need a whole educational campaign.
Oh, yes.
ACOG, A1, AAP, right?
Mm-hmm.
Yeah, like a whole campaign. Who's gonna produce? Who's gonna speak where? And yeah, let's do it. Yep.
One thing we are doing in Wales, because Wales is a tiny little state, is actually to put questions on these conditions in medical exams. Because otherwise, at your workshops will only come women and people that are interested in this, which they all fill certain demographics, and I'm tired of that. So what we're doing now is to lobby with medical schools to actually put in the exams questions on women's mental health. So you cannot skip that lecture, because otherwise you don't pass your exam. And I think that, at least that is what I think is yeah, the soft power, I think, at least my few cents on that.
I think it's a terrific idea. I think here what we're latching onto is the horrible reports on maternal morbidity and mortality, and talking about these severe disorders as being a contributor and trying to get more attention to them based on that. But boy, that is a real direct way to make sure that people
Mhm.
at least get some information. I like that.
I mean, when you think about the fact that it was not in the DSM and there is not one psychiatrist who was taught about it. When I was in medical school, I asked a faculty member I wanted to do extra training, and he said there was no such thing. And this
Yeah.
was at Cornell. I actually had to go to London and work with Chani Kumar to get training.
Then they show the psychiatrist.
In those days, Meg, pregnant women were depressed. They were fulfilled.
Right. Right, exactly. Thank you. I hope that everybody learned something from what we have discussed today. And I see there's a lot of people in the chat.
I felt better because she's just realizing it now. Yeah, it's so interesting.
Thank you so much, everyone.
Thank
Yeah,
you.
it was so
Thank you. This was terrific.
Thank
Good.
you.
Thank you.
Bye.
Wonderful.